Hello, everyone. My name is Dr. Julio Novoa. I'll give you a few minutes while we're adding your name to our list and invitations to the following groups that are actually part of our Facebook friends. First of all, we're inviting the ESSURE Problems Forum, Life After ESSURE in the United Kingdom and Ireland, the ESSURE group in Australia and New Zealand, the private post-tubal ligation syndrome group, the new post-tubal ligation private support group, links on mesh and other problems, mesh problems, surgical mesh complications, and the BIAALCL clinician and patient discussion group. I would like everyone to be invited. However, there are some private groups. I'm not members with the medical implant recall group, the VBAC groups, the breast implant illness groups, or the post-ablation syndrome support groups, but I welcome you to join our forum today. So, what I'd like to talk about is a series of commentary related to what we as physicians are doing wrong, and I'd like to give you a little bit of background on my history related to the forums. Number one, I'm an OBGYN, also a primary care physician and a cosmetic surgeon. I've been practicing in El Paso, Texas, the United States, for over 20 years, and for the past 6 years, I've been dedicating a significant amount of time to charity groups and also forum groups. So we actually established a medical ministry. It's not a significantly religious ministry, and a lot of people get confused about that, but half of my work that I do is actually pro bono, and therefore I do not have a conflict of interest related to trying to gain any money or make any money from the commentary that I make. Although I do help law firms related to giving correct information as far as medical malpractice is concerned, and also medical device issues. I don't spend a majority of my time trying to make any money from what I say. So I hope that that clears the air for a lot of people that are wondering, well, why is this doctor talking about what he's talking about? And I'd like to do a shout out to the ESSURE Problems Forum. I'm a member of that group, and that was the first forum that I joined. And there's about 43,000 members in that particular group, and as a coalition of members, they were active and trying to get the ESSURE permanent sterilization device taken off the market, working against the huge conglomerate of the Bayer Corporation. And shout out to those ladies and gentlemen in that group. They were able to get the ESSURE device taken off the market. The last legal insertion was allowed on December the 31st, but now since it's the new year, all ESSUREs should have been returned to the Bayer Corporation. So that was a great victory, although that's only one battle that has been won against that particular device, and I'll get into my commentary related to that. Now, if I'm using a mic, so if any of you are hearing a hissing sound or some type of audio issue, I do have a second mic, so feel free to comment. I have my assistant, Isaac, in the background. I can't read any questions, so feel free to document or comment, and we'll try to answer your questions. But what I wanted to talk about today were a number of subjects, and I apologize if I'm going to be looking down, because a lot of what I have documented here is something that you can actually go back on and Google it yourself. Or I'm only the messenger. I'm telling you things that I believe to be factually correct, but I do want you to go ahead and do your own research to feel confident and comfortable that the information that I'm giving you is accurate information. So the first subject I'd like to talk about is the rate of cesarean section and unnecessary cesarean section in the United States, and the lack of the offer of the vaginal birth after cesarean section. Now, although that's my first subject, the other subjects that I'd like to talk about is the autoimmune inflammatory syndrome induced by adjuvants, which is also known as ASIA, the ESSURE device in and of itself, which I've already touched base on, tubal ligation and tubal ligation syndrome, as well as the use of the NovoSure device for endometrial ablation, the issues with hernias, all types of hernias, abdominal hernias, inguinal hernias, and to my specialty, the use of meshes for stress urinary incontinence and also for vaginal prolapse, and which also includes the vaginal slings. And as a last subject, I'd like to talk about some issues with andropause and issues related to that and aging for men. So why is it important that I try to put all these together? Well, frankly, I wanted to be totally honest with you because I don't think that we as a medical profession have been very honest with our patients. Although you come to us with a desire for us to be completely honest, we are only human, and therefore our frailties, our uncertainties, and our negative characteristics will also be projected. Okay. What I wanted, first of all, to stress to patients is although I don't even want to say the majority, I want to say, although there's a lot of doctors that are very honest with patients, unfortunately, the majority of doctors in my specialty of obstetrics and gynecology, and also cosmetic surgeons and plastic surgeons, aren't really honest with patients. We are financially driven, and we lack the capability of being honest with patients, especially when we make mistakes. So this is not just an opinion, although I can assure you that in 20 years of my experience, I found that to be more the example rather than the exception. I did do a little bit of research on it, and you can actually go and you can say, why do doctors lie? And I found a couple very great articles on it. I know it's a bit dated, it's 8 years old, but this one was a survey showing at least some physicians are not always open or honest with their patients. Now, this is why we have issues with VBAC, why we have issues with ESSURE, with tubal ligation, issues with hernias, and all of the complications related to those foreign body reactions and complications related procedures, including the Da Vinci, which is more something that kind of like sprout out from the woodwork and has taken over the market, although it is not better than traditional laparoscopic surgery. So in this article, which I happen to agree with, it says that just over 1/10 of the time, physicians are not honest with their patients. I happen to think that it's a lot more often than that, especially when we get into issues with our egos, when something is brought to our attention that has been found by our patients to be true, we kind of shut them down. And I'm sure that many of you that are dealing with hernias, with the ESSURE device, with post-tubal ligation, have had to face this, where you're bringing some honest information to the doctor and the doctor's completely ignoring you. In some cases, the doctor is even laughing at you. Again, this is totally unprofessional and unethical conduct, but it happens to be true, and it happens every day. Many patients that come to see me for second opinion come in and they said they actually left the doctor's office, another doctor's office, crying because the doctor was laughing at them and saying that they were ridiculous for even looking on Googling something. And believe me, although sometimes Google doesn't provide you honest information, many times they do. So you want to rotate it? Go ahead. We'll try to rotate. Again, I apologize. We're not professionals. We're just trying to provide some information, and of course, since this is live, we just got to take it by the seat of our pants. Okay. So as I was saying, related to ethics and professionalism of doctors, it doesn't exist like it used to exist. I've grown up and have to work into an environment where we're seeing patients that are suffering from complications and problems because of the egos of doctors, the ignorance of doctors, and the inability to basically say, I was wrong and let me look up the information so I can give you right information. And that's what we're facing, and that's one of the reasons why I wanted to do the presentation today. So the first thing we're going to say right off the bat is that I consider that the majority of times in the fields of obstetrics and gynecology and cosmetic surgery and plastic surgery, doctors are not honest with patients. Now, we can throw forward that we're board certified or they're board certified and that makes them better than everybody else. And in reality, the board certification doesn't mean anything because it's how honest the doctor is and how willing they are to be open to information that's not available within our specialty and outside of our specialty. A perfect example is issues with meshes. Meshes, being a foreign body, do produce a significant amount of foreign body reaction not associated with the area where the mesh was placed. So it's hard for an OBGYN to even fathom the idea of how can a vaginal mesh be causing brain fog? How could the ESSURE permanent sterilization device make a patient gain 30 pounds? How can a hernia mesh that's perfectly placed cause chronic abdominal pain? How can tying your tubes cause you to be emotionally depressed or your periods change? It's because of a variety of reactions that your body has, and when there is a foreign body in it, this is what what we call a type 4 hypersensitivity reaction causes under what's called the ASIA, the autoimmune inflammatory syndrome induced by adjuvants. Now, I didn't make up that acronym. That was Dr. Schoenfeld from Israel. He's a well-known immunologist, and I encourage you to go ahead and look up his information related to the particular subject. But that's an umbrella of every other foreign body reaction that can occur can be umbrellaed under the ASIA effect. And we're talking about breast implants. We're talking about Filschie clips. We're talking about permanent sutures. We're talking about surgical clips, ESSURE, Hoka clips, celastic bands, hip replacements, abdominal and vaginal hernia meshes made out of polypropylene. Anything that's a foreign body that's introduced into your body can cause a type 4 hypersensitivity reaction as part of the ASIA effect. And that's where we want to start our basic understanding or our discussion today. So with that said, if you have a foreign body in your body and you're having symptoms of memory changes, brain fog, excessive weight gain, the pain not associated with that particular area, this is part of the ASIA effect. If you're having symptoms of fibromyalgia and chronic pain syndrome, or your diabetes is getting worse, or hypothyroidism is getting worse, or you didn't have lupus, but now you do, or Sjogren's syndrome, or now you do, or all of these conditions are getting worse, one of the last things that's ever looked at is the foreign body that's inside of your body, but that may be the primary cause of all of the symptoms that you have. We found this to be a very, very good example. We found that to be with the ESSURE permanent sterilization device. But the ESSURE permanent sterilization device, all of the history and all of its research and study was based on hernia meshes. And so we've been seeing the issues with hernia meshes for decades, as have we seen with the vaginal vaginal meshes. Oh, okay. Beautiful question. How is the reception amongst your OBGYN colleagues as well as your cosmetic surgery colleagues? Betsy Lopez asked that question. Let me make it clear to you. I'm not well liked in either the OBGYN field or the cosmetic surgery field. And I'm not well liked because I tell it like it is. And more importantly, it doesn't matter if I'm not well liked. I'm not asking you to be my friend. I'm asking you to research the information that I'm giving you and to understand that don't walk into a doctor's office thinking they're going to be honest with you, because the majority of the time, if they've done something that's making you feel worse, they're rarely going to admit that they're responsible for it. Okay, we don't follow the Hippocratic Oath. We haven't had to follow the Hippocratic Oath for decades. So when you think that we raise our hand or we pledge some type of professional ethics to the Hippocratic Oath, that doesn't exist. So if you can check that one off your list, we don't have to follow anything. We're rarely evaluated by our medical boards. If you're board certified, you're not going to lose your board certification because you're telling a patient false information. Very rarely are you going to see anything happen unless it's involved in a malpractice lawsuit. So My job is not to be liked. My job is to give you facts. My job is to give you, my patients, the people that are wanting to know the correct information. Those are the ones that I'm trying to address. But you make a very good point where it's very sad that even in El Paso, my community, there are still, that doctors have known for more than 20 years that I do VBACs, for example. They say that no one does vaginal birth after cesarean sections here. I do. We advertise it. We encourage patients to try because that's what the national and international guidelines say. We have patients that come in literally that said, I saw you on Facebook about ESSURE, and that's why I'm here, because my doctor said that there's nobody in El Paso willing to work with me with ESSURE. And I'm going, it's frustrating because we have people that communicate with us all the way from Australia and New Zealand, but I don't have people in my own backyard that know about us. And this is very frustrating. And maybe this is one of the reasons why we're trying to do more and more of these videos to try to get the message out. By the way, I wanted to shout out to our Australian, New Zealand friends, because Australia and New Zealand is very unique, not just with ESSURE, but also with breast implants, because it was that one particular study done a couple years ago in New Zealand and in Australia that really got the impetus related to talking about the issue with the lymphoma issue of the cancer related to breast implants, the BIALCL situation related to that. And I did have a copy and a little commentary related to that. I didn't want to jump ship yet, but let's go ahead. I hope I answered that particular question. A lot of you have followed me with ESSURE. The issues that I have with ESSURE now is just as bad as it was when ESSURE was on the market, but it's even worse now, because now more and more doctors are removing ESSURE, but they're removing it the wrong way. They're not doing preoperative studies on to find out how many ESSURE devices are in, how far in the coil is the fallopian tube. And because of that, doctors are trying to cut these coils. They're fragmenting the coils when there should be a hysterectomy that's recommended. They're actually causing more harm than good simply because they don't follow the guidelines established by the Bayer Corporation. Now, I may not happen to agree with Bayer on having the device out on the market, but the information that they provided is relatively accurate. What was interesting and surprising is that I went online today to see whether or not I could actually guide you to go to the ESSURE.com website from Bayer and get you the information for healthcare providers. That doesn't exist anymore. If you go to ESSURE.com, you're going to get the information for use document, which is 7 pages long and informative. But all of the research information on ESSURE and the physician's manual that used to be there isn't there anymore, interestingly enough. Okay, the issue related to, I'm sorry, I'm reading a question while we're trying to go. One of the important things to understand is not only what the information for use document, as well as the physician's manual for ESSURE had, as well as the FDA information had, is this. Even when the ESSURE device is perfectly placed, it's still causing foreign body reactions. That's under the Asia syndrome or the Asia effect. And therefore, all symptoms of a foreign body reaction, including an allergic reaction to it, including burning, sensitivity, pain, is present. And so to answer the question that was asked, why is ESSURE causing me pain and why is ESSURE causing burning sensation? In many cases, it's because your body is responding as a foreign body to a foreign body with a foreign body reaction of type 4 hypersensitivity, and that is causing a similarly allergic reaction to it. It's causing pain, it's causing systemic, in many patients, rashes, and these are the things that we're talking about with ESSURE. I don't want to take up an entire hour of our time only on ESSURE, but I wanted this as an introduction for you to understand that you're not getting the entire message on any one particular subject. So that's the message that I'm talking about with ESSURE. Now I'm going to jump a little bit because ESSURE is also associated with post-tubal ligation syndrome. For many decades now, we have known that if we manipulate the fallopian tubes, some patients, and I'm calculating about 5%, some patients do have changes in their menstrual cycles, They develop irregular bleeding or significant bleeding. They develop pain with intercourse. They have a significant change in their weight. They also start to notice cognitive changes. And many times it is due to a foreign body, such as the placement of a Filschie clip or a Hoka clip or Celastic band or ESSURE. But I wanted to address the fact that I believe, as many do of my colleagues do, believe that post-tubal ligation syndrome is a legitimate syndrome and should be addressed at that. Now, does a reversal of a tubal ligation always fix the problem? Not always. I believe that it only helps in about 30% of the cases. So once you've manipulated the fallopian tube, it may be a permanent situation. That's why I, as an OBGYN, always encourage a patient to make sure that this is going to be their last child with every consideration, any possibility that they would ever think about having another baby. That they need to make sure that they're not going to have any more children. Number two, always recommend that the male partner get the vasectomy. That before my patient says anything more about her wanting to get her tubes tied, I always say, have you talked with your husband or with your boyfriend about getting a vasectomy? The vasectomy does not change the sexual ability of the male partner. It does not, the virility, their libido doesn't change. That's all excuses as far as I'm concerned. And I can tell you because I've had a vasectomy and I've had it reversed and I didn't notice any changes. Now, I'm not going to put my example as the only example, but I'm going to tell you that it comes from the heart because I can tell you I had a vasectomy and I was back at work a couple hours later and I had a reversal of a vasectomy. And yeah, I did need a few days off for that. But when I'm telling you that males should have a vasectomy is because I got one. So I'm encouraging men to do what's right by their partners and help those particular partners avoid the post-tubal ligation syndrome because it is a real syndrome and it doesn't always have a cure for it once it's present. So that's what I wanted to talk about with post-tubal ligation syndrome. The next subject is going to be NovoSure. The NovoSure device is an ablation device. NovoSure is meant for irregular bleeding, and when you have irregular bleeding, one of the cures, if you're not able to tolerate the use of medication, one of the treatments is going to be to place a device in there which damages the endometrial lining to decrease the amount of bleeding. Now, this is a very interesting subject. You can get this on MedPage Today. I read it today, as a matter of fact, and they're talking about the issues with devices like NovoSure and how catastrophic they can be for some women. Now, the reason that I bring up NovoSure is because with the ESSURE, a lot of women that were getting ESSURE were also getting NovoSure. And I kept stressing to them, please do not listen to your doctors that are telling you the ablation is going to cure your problems. In the majority of cases, it's not going to cure the problem of irregular bleeding or problems with the ESSURE. It's just going to make them worse. Why did we decide that ablation was going to work, or why did we decide that it was an appropriate treatment plan for ESSURE? Because a couple doctors did a few studies on a few hundred women and said, whoa, look, it works. It doesn't damage the ESSURE device. Therefore, we're going to go ahead and recommend it for treatment of ablation. Let me tell you, that's not enough patients, and all they were looking at was whether or not it was going to damage the ESSURE device. They were never looking at, was it going to cause any more problems with autoimmune responses? Was it going to cause any long-term effects on the patients? Because they didn't know. They simply were pushing it as an alternative to doing a hysterectomy without significant study. And the fact of the matter is, here's a perfect example. The NovoSure device, as well as the other devices, was never designed and never had the sensitivity to confirm that if it was placed incorrectly, or if the ESSURE device was placed incorrectly, that it wasn't going to cause significant damage to the uterus or to the internal organs. The NovoSure device is known, it's not fail-safe, it's known to damage the uterus, it's known to have perforated the uterus, and is known to have burned the internal organs of patients and even associated with fatalities. All of this information is available in the MAUD data off the FDA website. But this is a beautiful article that I would encourage everyone to read. And this is an independent evaluation from MedPage Today. I consider it to be a good article on discussing NovoSure and why. Be careful with getting NovoSure because the history of NovoSure is similar to the history of ESSURE. The reason we were pushing NovoSure is because we could do NovoSure in the office. And we could do it in the office because we were going to get paid more for doing NovoSure in the office, as well as other types of techniques like this. We get paid more for doing it in the office, and therefore some women were having significant issues with pain management in an office setting, where I originally started doing them in the office as well, until I realized that it's causing too much discomfort for the patient, and we started doing it in the hospital setting. There are doctors that are still doing it in the office when I really believe that it should be done in the hospital. And it has a failure rate of 20 to close to 30%. So if you get it done and you have a major complication, you're still going to need a hysterectomy. With a failure rate that high, you might as well, at least you should be properly informed. So all those ladies that have gotten NovoSure or ablation procedures done, think again about how well and how good they were, and what the potential complications were. And if you did have a complication with the NovoSure or another device of a similar nature, maybe now you'll understand why you had that, and it wasn't really your fault, and it should have been better explained to you related to NovoSure. The next subject I want to talk about is hernias, which I had touched base on before. Most hernias that are the most popular hernia devices to fix hernias are going to be the plastic meshes, most often polypropylene meshes we got our experience and understanding of it based on the placement of hernia meshes in the abdominal wall. However, we have found because of the research that hernia meshes, they cause an inflammatory response under the Asia effect. They cause shrinkage. They cause the scarring of other tissue onto the hernia mesh, and they cause a major issue on long-term effects for some patients that are chronic in nature and difficult, if not impossible, to remove the hernia mesh after it's been placed. This goes as well as for inguinal hernias, meshes that are placed, where 90% of them are going to be of the non-absorbable polypropylene type, as well as vaginal meshes, which were taken off the market. The vaginal meshes were never found to be safe and effective, and the FDA pulled all vaginal meshes off the market just in the past year to 2 years. That's how bad the vaginal meshes were, and their history was based on the safety and effectiveness of hernia meshes. Now, another question, I'm sorry. Okay, the question is, can gallbladder clips cause autoimmune reactions? Any foreign body can cause an autoimmune reaction. The problem is that there's very little or no research into whether or not surgical clips, such as those that are placed on the gallbladder or for bleeds, do cause some type of foreign body reaction. What bothers me is this: there are plenty of patients that have had hernia meshes removed, have had Filschie clips removed, have had ESSURE devices removed. They've had foreign bodies removed because of a foreign body reaction, and yet the surgeon is using surgical clips to stop bleeding rather than a suture, and putting another foreign body into the body of that person when they were taking one foreign body out because of an allergic reaction or an Asia effect. So where's the common sense in that? If you're going to have a procedure done where they're removing a foreign body, why would they ever put in or leave in a different foreign body? So I'm sure that it's upsetting for all of those that do have surgical clips in place. Why did they do that? Now, a lot of what we're learning now, we didn't know before, but this is not recent information. And so if there are still doctors that are placing surgical clips in, they should know better. At least they should properly inform the patient, I'm going to use surgical clips. Are you okay with that? And in many cases, the patients aren't. They don't want another foreign body placed when they just had one taken out. So the key here to remember with hernia meshes, whether or not they be abdominal, inguinal, any type of hernia mesh, vaginal meshes, and the urethral meshes, is that they all cause foreign body reactions, all cause erosion, all cause pain, and shrinkage, which makes it almost impossible sometimes to remove those meshes. Aha, thank you. Perfect. That's the next subject. Here we go. These are available online, OBG management. Now, a lot of patients say, well, why, if you're telling me all of this, why would my doctor suggest that I get a transurethral mesh, retroperitoneal mesh, or transobturator mesh placed for urinary incontinence? And that's a very good question. So I went back and I tried, first of all, I read the article, but then I went back and I went on the FDA website and we looked at urogynecological surgical meshes. This has more to do with the subject of vaginal meshes, which of course they were taken off the market because they were not found to be safe and effective. And then I read FDA website, the considerations about surgical mesh for urinary stress incontinence. And this is based on the question that was asked. What are the alternatives to meshes that are, if you have stress urinary incontinence? But a real quick commentary is that why are non-absorbable or permanent meshes still being placed for the management of urinary stress incontinence? Very good question. The reason why is because they're highly effective in doing what they're supposed to do. 80 to 90% success rate if you use a non-absorbable or permanent mesh to manage stress urinary incontinence. The problem is that it also has a very high rate of complications related to it. Now, all of the studies that I read, they weren't addressing autoimmune reactions, which would be a new topic. Would surprise me that they weren't talking about autoimmune reactions. But what they did talk about as a topic was pain, which is significant, and about 10% of patients will have chronic pain with the placement of a stress urinary incontinence mesh, as well as erosion or extrusion of the mesh, and they describe it as only 2%. Only 2% of the time are you going to get an extrusion or erosion of that particular urinary stress incontinence mesh. I happen to disagree with it. I've seen close to 20%, but I actually believe that it's because it's being underreported, and but that's why doctors are being told, or doctors are reiterating the same commentary, that stress urinary incontinence permanent meshes only have an erosion rate of 2%, and therefore we can continue to use them, or we recommend that they be used. And in reality, that's not the case, but that's the explanation. So instead of placing a permanent non-absorbable mesh, I would have to recommend that we go back to the traditional meshes that we used to use, such as the biodegradable ones from either cow or pig. Now, there's also the fasciolata mesh, which a fasciolata mesh that we used to use, or we still use, and I remember that from my training back in residency, and we're talking about 20 years ago, where you remove a portion of your own mesh, own fascia, and use it as if it was a mesh into that tissue. So, is it as good as a permanent mesh as far as its permanency is concerned? No, it's not, but it's less likely to cause side effects and complications. And if it does cause a problem, it's not as difficult to either manage or remove as compared to a permanent mesh that will shrink and embed itself in viable tissue, and then it makes it exceptionally difficult to remove after that has happened. I hope that answers the question. And also, like I said, this is what I got, just a quick research, and it's a throwaway magazine that we get, but this is why doctors are being brainwashed into thinking that, hey, it's still okay to use non-absorbable meshes for urinary stress incontinence because this said so. And in reality, you have to do a little bit more research to understand that, yeah, it's a great device, but it also has incredible side effects that can be permanent and debilitating, catastrophic for the patient. And a lot of the studies are only talking about 1 to 5 years out. So if you have a vaginal mesh or stress urinary incontinence mesh in place for more than a year to 5 years, there's really little research on how high the complication rate is with those particular meshes. So, andropause, real fast for guys. I'm over the age of 50 now. I started noticing that there were issues with me as far as my strength level was, starting at around age 35. And we believe that there is a condition known as andropause, where men, their testosterone level changes beginning at age 30. So there are remedies related to, including the replacement of testosterone, including the use of other medications for males to maintain strength, even especially if it's causing problems with libido. And that was really an off subject, but I did want to include males not only to be critical of the vasectomy, but also the fact that I don't want men to think that there's not subject matter that's actually accurate, rather than spending a lot of money on websites that are not going to give you correct information, and you're going to spend a lot of money for things that are much less expensive if you find the right doctor that's willing to work with you. Most of the time, primary care physicians, family practitioners are willing to work with you. Even though I'm an OBGYN, I do work with male patients, and I wanted to address those issues, that there is an alternative to what you're seeing on the websites, including Facebook and Google searches, for male andropause, because it is a condition that can be managed and helped. So the last subject, and this is, thank you very much, ladies, related to breast implants. I am a cosmetic surgeon. I do place breast implants in, but I screen my patients very, very closely. First of all, any patient with an autoimmune condition I don't consider to be a candidate for breast implants. Patients that suffer from hypothyroidism, diabetes, morbid obesity, lupus syndrome, Sjögren's syndrome, Raynaud's syndrome, chronic fatigue syndrome, fibromyalgia. None of these patients are candidates or should be carefully screened for the placement of breast implants. Next is a group of women that are constantly recommended, that it's constantly recommended to them to get breast implants. And that's going to be women that have suffered from breast cancer. And that is not, I consider it to be a high-risk group, even though the implants, especially silicone implants, were designed as reconstructive devices and women that have suffered from breast cancer. And the issue with that is that in reconstruction and breast cancer, the complication rate of the placement of either saline or silicone implants is approximately 30%. So anywhere between 20 and 30% of the time, women with reconstructive breast augmentation from breast cancer or similar conditions have a complication rate requiring additional surgery between 20 and 30% of the time, or 1 in 3 chance that they're going to get, at minimum, a capsular contracture, which is a rejection of the body, a foreign body reaction under the Asia effect, and then an additional surgery is required. I don't think most women that have suffered from the catastrophic effects of breast cancer want to have to go through another surgery, or the potential risk of having another surgery, at a risk of 1 in 3. And yet plastic surgeons, cosmetic surgeons are telling them that yes, this is an alternative rather than your own tissue. We can go ahead and put a breast implant in there, when the plastic surgeon and cosmetic surgeon is not telling that patient that they have about a 30% chance that they're going to need another surgery. With that said, textured implants were created in order to reduce the risk of a capsular contracture, and they were great at doing that. But now we found out that they can be associated with non-Hodgkin's lymphoma. And although the number of patients suffering from this cancer is not very high as compared to the general population, it's high enough to have gotten the Allergan Corporation to take their textured implants off the market. What I wanted to stress to you about an example of how your surgeon was not honest with you is the fact that the information related to this particular condition has been available from the FDA since 2011. And in 2012, the Plastic Surgery Association, they actually started talking about it on their websites and created a data bank related to it to collect information on it. The problem was that they weren't telling their patients about it, or at least not warning them that this condition was a possible condition. So if you got implants placed after 2011, there's a good chance, textured implants, not saline or smooth implants. If you got a textured implant placed after 2011, did your plastic surgeon or cosmetic surgeon tell you that this particular cancer was a potential risk for you? I don't think so. No. Okay. If you're asking, the question is, do implants need to be swapped out if there's a risk of cancer? First of all, unfortunately, I can only give you a limited amount of information based on what recently has been proposed. Number one, if you have smooth implants or if you have non-allergon implants, such as the Mentor series, then the risk is considered to be at the same risk as the general population. So implants do not have to be removed. If you do have textured implants of the Allergan Corporation series and you don't have any symptoms, then they don't have to be swapped out, although Allergan has offered to replace the implants but not pay for the cost of the replacement, has offered to pay for new implants if you want to get them swapped out. And of course, you have to pay for them to get swapped out. Now the question is, the FDA as well as the plastic surgeons say that if you have no symptoms, then it's not necessary to take out the implants or replace the implants. If you do have symptoms such as breast swelling, breast tenderness, seromal fluid in the pocket, or enlargement or thickening of the capsule of the implant, then that's a good indication that you should have it studied, a biopsy done, and at least take out a portion of the capsule, if not take out the entire capsule en bloc. So that's as much information as we know right now. I recommend that if you're going to get them swapped out, then you should at least consider the fact of getting the entire capsule removed, all of the serosal fluid tested, and of course swap them out for smooth implants or saline implants. That would be what I would recommend, but it's not just my recommendation, it's generally what has been recommended or is coming out now as a recommendation. So we're not asking that you automatically get them removed or swapped out if you don't have any symptoms, but in reality, if you can afford it, that should be a strong consideration. Last point related to that, I'm going to read a question, I'm sorry. Okay, there's a patient or a person that said, I was told that my implants, there's no risk related to my textured implants. Number one, the probability of a complication related to the textured implant series is based on the Australian and New Zealand study, which thank you very much, ladies from Australia and New Zealand, because your country was closely monitoring this condition, and because of the way that they document complications, that is the most accurate information that was available. It was available a couple years ago, but now you're finding out about it. And so what happened to all of those ladies that got textured implants 2 years ago when they should have been told about this study in Australia and New Zealand? But that's a separate subject. So the probability of getting a complication of this particular cancer in the general population is about 1 in 30,000 to 1 in 100,000. And again, you can throw a dart and you would not be wrong in either one of the numbers. The fact of the matter is the calculation is that there's a 1 in 2,000, between a 1 in 1,000 and 1 in 2,000 chance that you're going to have a problem with the Allergan series. And one recent study that I read narrowed it down to as low as 1 in 400 or 1 in 385. So someone that tells you that there's no risk whatsoever is not being honest with you. The risk is there. Do you consider 1 in 500, 1 in 400 to 1 in 1,000 to be high risk? Only you can determine whether or not that risk is high enough for you. I recommend that if you can, get them swapped out, because we're still learning about this condition. And you don't want to be a guinea pig for somebody that told you 5 years from now, well, we just didn't know that at the time. So that's my answer to that question. Okay. Here's an important comment, and a very, very difficult one, and why I talk about the issues with breast implants in general. The same comments that are made related to textured implants about whether or not there's a problem and a risk for non-Hodgkin's lymphoma, this particular type of cancer of the lymph, not of the breast itself, is this. The most common complication related to breast implants, other than infection, is capsular contracture. That is, your body's rejection of the implant, knows that it's a foreign body. Development of a thickened capsule around your implant and that in many cases is a grade 3 or grade 4, where you can actually physically see that there's something going on, it's deformed. The capsular contracture being an autoimmune reaction to a foreign body, how do you distinguish the difference between that benign condition and a cancer related to this particular type of cancer? You can't. If there are patients that get seromal fluid buildup in capsular contracture, as well as a particular condition of this cancer. So if the doctor's telling you, oh, your capsular contracture, nothing to worry about, how do you know? That doctor doesn't know. The only way you can be sure is to take out the implant, take out the capsule, test the fluid, and see. The majority of time, you're absolutely right, it's going to be benign. But what's the chance that, can you sleep at night knowing that I got a capsular contracture, I have textured implants, I have this problem, this potential problem, I'm going to go ahead and sleep well at night? I don't think most people would. So I have a real concern when you have a potential swelling, tenderness, capsular contracture of a textured implant, and simply ignore it or simply say, my doctor said there wasn't a problem. Now, is there an issue with smooth implants? We haven't found it to be an issue. Therefore, I can't give you that it's absolutely not an issue at all. But even in the cases where they have found some cases where they have this particular cancer and they've had smooth implants. So you can't automatically rule out all cases. I hope that sort of answers the question, that it should be followed up more closely. I recommend that you follow the instructions or the recommendations of your doctor. But for my patients, I do serial compression ultrasounds, as well as recommend MRIs. And in cases where, you go with your sixth sense, take out the implant, replace it, take out the capsule, let it grow a new capsule around your implant. And that's the best way that I feel that I'm informing my patients of the potential risks of these particular, the benign capsular contracture versus BIA-ALCL. Okay, next question. Sorry, Isaac can't write that fast. Okay. The question was that a patient started losing their hair after a capsular contracture. Okay, let's stress that again. A capsular contracture is your body's exaggerated response to a foreign body. The foreign body is the implant. Now, we can argue all day, or I can argue with my colleagues all day on whether or not it was a biofilm, whether or not there was a contamination that caused the capsular contracture to form, whether or not there was a hematoma or a seroma that caused the capsular contracture to form. We can argue all day about that. The point is that something triggered your body into realizing that a foreign body was there, which caused it to form a capsular contracture. Now, you have a capsular contracture. And for all the breast implant illness patients, this is what's happening. The breast implant illness condition, syndrome, is part of the Asia effect, okay? If you wanted to try to connect the dots, that's what's happening. The Asia effect is the same effect as with Filschie clips, with hip implants, with abdominal meshes, with vaginal meshes, with the ESSURE permanent sterilization device. All of those conditions fall under the Asia effect. So let's go to breast implant illness, because hair loss is part of the breast implant illness. Capsular contracture can be part of the breast implant illness. All right, so from head to toe, what are the most common breast implant illness symptoms? Number one, hair loss. Number 2, cognitive changes. Number 3, memory loss. Number 4, changes in vision. Number 5, which cross across all of them, which I forgot to mention, is dental caries. If you're starting to have problems with your teeth, that might be associated with a foreign body reaction of any of the ones that I just talked to you about. Okay? And once the cascade starts, it may be not possible to reverse it, even if you get rid of the foreign body. Now, the heart, cardiomyopathy, ventricular tachycardia, supraventricular tachycardia, okay? Pulmonary problems are as well. We're talking about excessive weight gain, chronic fatigue syndrome, fibromyalgia, okay? We're talking about triggering or worsening conditions similar to lupus, Sjögren's syndrome, Raynaud's syndrome, okay? All of those can become worse. So if you're feeling like you're dying and you're saying, I've got breast implant illness, it's because it's falling under, or probably you're being affected by, under the Asia effect. So all of you, all of the people that have foreign bodies in their body may have the same symptoms, may have the same conditions, even though they're not the same implant. ESSURE as well as breast implants. Okay, the SRX versus the saline implant. SRX are silicone implants. Now, the SRX series was designed not to a very low risk of rupture, and commonly known as the gummy bear. Okay, but if you do happen to cut or damage a gummy bear implant, it still bleeds. It bleeds silicone. So, as far as safety is concerned, the probability of a saline rupturing or leaking is about 2%, but all it has in it is salt water, and so less likely to cause a complication. And you know that it's ruptured because you wake up one day and your one breast is bigger than the other, as compared to the SRX series where you're going to need to do high compression focused ultrasound or MRI, which, by the way, is in the informed consent that you should be getting an MRI done every 2 to 3 years. But doctors don't tell you that because your MRI is going to cost you more than your breast augmentation did in the number of times that you have to get it done. So that's the answer to the SRX saline as far as I think that you asked the question. But going back to breast implant illness, we see that when you remove the foreign body, when you remove the mesh, when you remove the ESSURE, when you remove the breast implant, and it can be saline or silicone, when you remove hip implants or stents, any of those that are removed that you thought had a symptom related to it, and the symptom disappears within an hour, a few hours, or a few weeks, you probably had a foreign body reaction to that. So I do want to stress to women that have breast implant illness, if you're that severe, that your condition is that severe, the recommendation is to remove the implant that's causing the insult. However, although we do see that there's a significant or complete reversal of symptoms in 80 to 90% of cases, there's still going to be about a 10% residual effect. And why is that? Because although the implant may have caused the foreign body reaction, you may have been predisposed to have the reaction that was prolonged, or it triggered an underlying condition that you already had or predisposed to have, which now is chronic, such as you may have lupus, and your lupus may get worse with a foreign body in it, but your lupus may not have started to become an issue for 10 more years, but you got breast implants placed at age 20, and so now lupus is more of an issue in your 20s rather than in your 30s to 40s. I hope that kind of gives you an understanding. The key thing is that it's not in your head. If you actually got these severe symptoms, go to a doctor that understands autoimmune reactions such as rheumatologists, hematologists. And here's the key here. I'm a primary care doctor, I'm an OBGYN and a cosmetic surgeon, so I've had to learn a variety of information across specialties. When an OBGYN focuses only on OBGYN issues, they're not going to agree with you when you have brain fog or cognitive changes because you have an ESSURE device in or a vaginal mesh in. The same thing applies. Your cardiologist is not going to think that your ESSURE is causing your supraventricular tachycardia because of the ESSURE, because your cardiologist knows nothing about autoimmune reactions related to ESSURE. And similarly, your plastic surgeon who put in your breast implants is not going to know that your chronic fatigue syndrome and fibromyalgia is being caused by your breast implants, because that doctor is a plastic surgeon and not a rheumatologist or an immunologist. We as doctors have got to open up our minds and start studying other specialties to understand that the potential issues that are going on with these foreign bodies are actually things that we were also responsible for, because we're not learning anything about them. We're simply shutting down and cutting our patients off and dismissing their complaints. Yes, the question was, can I get an autoimmune reaction years after having had a foreign body placed, specifically breast implants? Let's be clear. The human body is designed to be as strong as it can be. The younger you are, the stronger your immune system tends to be. As we get older, our immune system becomes compromised because of age, okay, or longevity of a particular insult. So if you have breast implants and you had them placed at 20 or had placed at 30, as we get older, we notice age. We notice that becomes a problem. And autoimmune reactions tend to get worse as we get older, okay? If the response to the foreign body wasn't really exaggerated or significant when you were in your 20s, they can become worse as you get older. We see that commonly with vaginal meshes, urethral meshes, and the ESSURE device, where 5 years go by perfectly fine. 10 years go by. All of a sudden, the patient starts to feel horrible, and all of the other cascade symptoms start to appear. But we remove the ESSURE, and the patient feels better. I believe that if you're starting to notice symptoms 12 years out, first of all, if you've had implants for 12 years, let me try to stress something. Get your implants replaced. They're not meant to be in the body forever. And it's possible that just the fact that the implant's in there, the older tissue that surrounds that implant may be causing your own response. You need to get that taken out. You need to be redone, because they should be replaced every 10 years anyway, regardless of what your doctor says, especially those doctors that say that gummy bear implants don't have to be replaced. They're not lifelong devices. They should be replaced, or considered to be replaced, every 10 years or so, simply because, like any device, they age and they are not as good as they were when you first put them in. So I hope that answers that question. Okay, what studies should be done to test for mesh shrinkage? The most sensitive ones that we're aware of are going to be the MRI, because the MRI is able to distinguish on a millimeter level distinctions in tissue layers, so in 3 dimensions, better than either X-ray or the CT scan. So if you're looking to find a particular issue, probably the most sensitive test is going to be the MRI related to meshes. That's my opinion. Can you tell me what the SVT means? Supraventricular tachycardia. Oh, okay, I'm sorry. Show it to me again. Okay, I want you to Google something, because someone has a question about supraventricular tachycardia. Supraventricular tachycardia has been associated with autoimmune antibodies, most commonly associated with lupus. So if you want to Google that, Google supraventricular tachycardia, lupus. It'll give you a little bit more information than what we can talk about here. And that's the association. So just like lupus, other autoimmune conditions can trigger supraventricular tachycardia. And again, let's go back to 2 things, because I thank God it reminded me. I appreciate that. Is back to the dental caries. A lot of patients say, I'm having a lot of problems with my teeth, and I have a foreign body. Could it be associated? We have seen it. I've seen it with ESSURE especially, that patients, they had very, very good teeth, and then they start to notice that their teeth are breaking, a lot of cavities, and literally they're losing their teeth. Some patients losing 5 or 6 teeth at a time, and their dentist can't figure out what the problem is. So what we've noticed is that with the conditions of lupus and Sjögren's syndrome, Sjogren's syndrome, sorry. The condition of changes in saliva amount as well as shift in natural bacterial flora may explain why teeth are breaking or the issues of dental caries. So very, very important that I think that should be followed up. You should see your dentist at least twice a year, if not closer, if you have a foreign body in your body. And that includes ESSURE as well as breast implants. Now, what I happen to recommend to my patients that have breast implants is this. If you have a bacterial infection, especially if you're going to go see the dentist, or if you've got an upper respiratory infection and you know that it's bacterial in nature, I want you to come and see me because I'm going to give you, or we're going to talk about putting you on antibiotics, because we have seen that bacterial infections can carry or can move from the lymph nodes around the neck and the face, can transfer over, the bacteria can transfer into the lymph nodes of the axilla and then contaminate or infect the particular implant, and which leads to capsular contracture. So I often recommend that a patient is going to have dental work done, come in, we're going to give you an antibiotic to put you on it ahead of time, and you can also talk to your dentist about that. But that's me, because of how many implants I had placed, well over 3,000, and we try to keep the risk of capsular contracture as low as possible. Okay, question is twilight sedation, removal of the implant and the explant. Is that including the capsule? Isaac, the question asks about removing the capsule?
No, just
okay.
explant.
Let me make something clear. My office is the only level 3 office-based surgical center for cosmetic procedures and OBGYN procedures in El Paso. There are not very many of us. So when I make a commentary related to fully conscious versus twilight sleep, it's because I have a lot of experience. I've published, we've done well over 3,000 breast augmentations as a fully conscious, awake cosmetic procedure. As a matter of fact, you can go to YouTube and watch the original one, awake breast augmentation in a 68-year-old woman. We don't use twilight sedation when we do breast augmentations. We could, but we don't. I have also done the removal of capsular contracture as a fully conscious procedure rather than in twilight sedation. If you're talking about replacing an implant and keeping the same capsule in place, then either fully conscious or awake swap out is possible, or IV sedation, twilight sleep is possible. The problem is this. Because of the capsule, it is difficult to anesthetize the tissue around the capsule, because basically it's scar tissue. And so even when you do IV sedation or twilight sleep, it may not be good enough to control the pain that the patient feels. And therefore, the general recommendation, if you're going to remove the capsule, is to do it under general anesthesia. Yes, it costs more and there are more risks with it, but overall the safety level and potential control of bleeding is better under general anesthesia. Now, I say that because I do fully conscious, but I know what the scenario is and what the potential risks are. So in this particular situation, I would say simple swap out, then you can do it awake. IV sedation is a little bit more complicated, more problems, potential complications, but general anesthesia would probably be your best choice if you're going to remove not only the implant and replace it, but also replace or take out the entire capsule and block. Are we good? All right. Well, it's been a little bit over an hour. Thank you so much for joining us. If it was if you got a lot of information out of it, I'm glad that you did. And we will see whether or not we can do another one very soon. I'm not sure exactly when, but we had some time off today. So please share this. I know we covered a lot of subjects, and I hope that this at least gives you some idea of exactly why we as doctors actually don't know what we're talking about many times, and that it shouldn't keep you from researching and trying to find out if you actually have an issue, what could really be the cause of that issue or that problem. Keep searching. We hope we provided the proper information. Thank you so much for watching.